EUS Guided Small Bowel Anastomosis for Afferent Loop Syndrome. Case 1. 58-year-old male presented with jaundice, abdominal pain, and vomiting in January 2023. He had prior history of esophageal cancer in 2021, status post neoadjuvant chemotherapy, followed by radical surgery with total gastrectomy and esophagojejunostomy. Surveillance CT in 2022 showed no recurrence. Labs on admission revealed elevated LFTs with bilirubin of 6.7 and low albumin level. A PET CT scan showed dilated jejunal limb connecting to the hepaticojejunostomy, suggestive of afferent loop syndrome as shown in the cartoon on the right. Management options were discussed, including surgical management, IR intervention, or EUS guided decompression of the afferent limb. EUS guided jejunojejunostomy for afferent limb syndrome was planned as shown in the cartoon here. Echoendoscope was advanced across the esophago-jejunal anastomosis and a dilated jejunal afferent loop was identified. 19 gauge FNA needle was then advanced and contrast injected into the dilated afferent loop. An avascular window was identified with a good runway of 4 centimeters. A cautery-enhanced lumen-opposing metal stent was then deployed successfully across the jejunum into the dilated afferent jejunal loop. The inner flange was then deployed inside the jejunal loop, followed by deployment of the outer flange with free flow of sludge and bile. Post-procedure, there was decompression of the limb and the metal stent can be visualized here. Patient continued to have vomiting, however, but the bilirubin improved and LFTs improved. An upper GI endoscopy was then performed and the scope advanced inside the jejunum and the metal stent with its open flanges can be seen obstructing the jejunal limb. The scope was then maneuvered to identify the distal jejunum. A guide wire was then advanced, followed by placement of a nasojejunal feeding tube to ensure the food delivery. Nasojejunal feeding tube was removed in 4 weeks. Patient is asymptomatic 1 year later. Case 2. 57-year-old female presented with recurrent vomiting, jaundice with fevers and chills. She had history of hypertension, diabetes, and ampullary cancer, post-pylorus preserving pancreaticoduodenectomy 2 years back. She received 8 cycles of chemotherapy following her surgery. Labs revealed anemia, leukocytosis, elevated LFTs, jaundice with bilirubin of 9.4 and low albumin level. A CT scan showed dilated jejunal limb, which was the afferent loop, with dilated intrahepatic ducts, as well as multiple cholangitic abscesses. She also had some mild ascites. EUS was performed and this echoendoscope was advanced across the pylorus and the duodenojejunostomy anastomosis can be visualized. On echoendoscope, the tube placed during surgery was identified as a marker of the dilated afferent loop. An avascular window with a 3.5 centimeter runway was then identified, and a cautery-enhanced lumen-opposing metal stent was advanced across the duodenal bulb into the dilated jejunal loop, and the inner flange is seen being deployed, followed by the outer flange inside the duodenal lumen with free flow of contrast and bile. Post-procedure, patient had gradual resolution of jaundice, fever subsided, and patient was started on oral diet, which she tolerated well. She was discharged in 3 days. A follow-up 2 months later, patient had no recurrence of symptoms. EUS guided small bowel anastomosis is feasible and effective for management of afferent limb syndrome.